This is Dr. Kornman. We're going to talk about a transforaminal lumbar interbody fusion using minimally invasive microsurgical technique, stealth, and the O-arm. This is a typical picture of a very degenerative L5-S1 disc. The disc height is collapsed and you can see a black vacuum phenomenon. This is the MRI finding, where you can see the lowest disc is much collapsed compared to the ones above, with bone signal changes indicating stress fracturing. This is a discogram, where the two discs above the degenerative disc are obviously normal with a cotton ball appearance, and the L5-S1 disc is quite degenerative. This is the technique of the pedicle screw insertion. We start first by putting a small frame on the spinous process, which you can see protruding out of the blue sheets there. We cover it with a clear sheet in order to protect the sterility of the field. This device is an O-arm. It's an intraoperative CT scanner, and this device can lend us images not only front to back and side to side, but top to down, which makes surgery much safer and much easier for insertion of these screws. We're going to watch how the CT works. The light on top comes on, and you'll see this image spin around, and this is the actual CT scan and how long it takes. This CT is 1/3 the typical exposure of a standard CT performed in a hospital. Here are the tools that we use in order to identify the levels. The incision has already been made. That device that is protruding out is attached to a spinous process. The device that I'm holding identifies the level that we're at. After I identify where the screw is going to be inserted, I use a small burr to create a starting hole. Once that starting hole is created, then I use a tool called a pedicle finder or pedicle awl to find the pedicle, and this is done under direct visualization. You'll see here that this device that I have has these balls attached, and these balls reflect off of a frame, and this is very similar to a GPS device. You can actually insert the device into the pedicle without any problems because you're looking at the pedicle both a front and a side and a top-down view. You'll see this in a second here. We'll switch to the screen and you'll see exactly what I'm staring at. So there is the vertebra. The blue device is the awl itself, and you can see that I can easily find my way down the pedicle by the feel of the device while I'm actually physically inserting it, and by the visualization that I see both on the front, side, top, and middle views. Once this device is in, we have a tract that the screw is going to follow. We remove the device, and it should be in there pretty rigidly, and then we want to tap the hole just like you would tap a wood screw. And so we take the device out that finds the pedicle, and this is the tap that we use to tap the hole. After we're finished with the tap, we'll then insert the screw itself that's attached to the same type of tracking device that we used to find the hole in the first place, and we can follow the screw down into the pedicle. So here the tap is being removed. Here the screw is now being inserted into the tapped hole. And then once we visualize its flight plan, so to speak, the screw is inserted. And it should be inserted with some good force because the pedicle should be a strong pedicle and should hold the screw well. These are the screws that are going to hold the vertebra in place while the fusion is taking place. Once the screw device is removed, then we insert the other 3 screws, but here is what I'm visualizing when the screw is being inserted. You can literally watch the screw marching down the pedicle and avoiding all of the sensitive structures such as the nerves and the vascular supply. This is 1 screw insertion, and 4 screws are inserted at this point in order to be able to complete the surgery. Once the screw is finished being inserted, we can actually save the screw in position. Then we test the screw. We run a little bit of electricity through the screw, and by watching this monitor, the technician, the neuromonitoring technician, can determine whether the screw could be irritating a nerve root or not. And with this device, the O-arm in Stealth, it's almost impossible to have a screw irritating a nerve. This is what the final screw insertion looks like from the front to back view. You can see that white metal which is attached to the spinous process. That's the registration probe. We'll have a side view here also, and you can see the screws inserted and where they exist in the morphology of the vertebral body or the sacrum on the bottom screws. We complete the rest of the surgery after we then perform a second O-arm spin to confirm that the screw position is appropriate. And once these are done, then we can review the CT scan, and here's a good example of the vertebra and the screw positioning where you will see the screws are nicely placed within the pedicle and within the confines of the vertebra, indicating that there is no screw that's going to irritate a vascular structure or a nerve root. We have postoperative films. This is a front-to-back view of the TLIF. The white arrows point to the solid fusion between the vertebra. Here is the arrow pointing to the solid fusion between the body of L5 and the sacrum. And then this is the CT scan at 6 months, indicating a rock-solid fusion with the arrow pointing to the solid fusion. We'll see this is the front-to-back view, again, of the interbody with solid bone formation. And this is just at 6 months. It really gets much greater at a year. Again, the arrow's pointing to a solid fusion. And this is exactly how we insert pedicle screws using the O-arm. Thank you.